Hello, everyone. The Atari at y'all today. So after reviewing today in Part 2 Medicare health plans, you'll be able to explain what types of Medicare health plans are available, who is eligible in the different types of plans, describe the different types of special needs plans. They'll be referred to as SNPs. Describe features of different Medicare health plan types, different types of benefits offered by Medicare Advantage plans, and explain how Medicare health plans work with prescription drug plans, and explain enrollee rights concerning their Medicare health plan. So let's buckle in. As always, feel free to interrupt me. This is about 50 slides. So if you have questions at any point during this, just go ahead and unmute yourself and ask it. If it gets too crazy, then we'll have Charlie monitor it, but I don't think it will. Here we go. So part is Medicare Advantage plans. If you remember yesterday, we learned about Plan C, and today we're going to talk about Part C, two totally different things. Medicare Advantage plans, MA, also known as Part C, offer benefits through private insurers to cover all of Medicare A and B, and then some. Many also cover Part D prescription drug benefits. We refer to those as MAPD. And all plans have a maximum out-of-pocket limit known as the MOOP for basic benefits. Can somebody tell me, this is a trick question, but I've actually had this question asked, so I want to make sure everybody understands. Faith, do not answer this one. Can somebody tell me if my Part D drug cost goes towards the max out-of-pocket on the insurance plan through a Medicare Advantage, meaning the MOOP for like inpatient hospitalization, doctors, x-rays. So if the MOOP is $3,900, is the cost, the $2,000 limit for prescriptions, is that going to apply towards my MOOP for the plan for health? No, it's not. I've actually had agents ask me that. They have told somebody before that the cost of their prescriptions would go to that maximum out-of-pocket limit for basic benefits. Anything that is medical has a separate maximum out-of-pocket than the Part D drug plan, just so everybody knows. Many MA plans also offer additional benefits that Medicare does not cover, known as supplemental benefits. We all know what those are. All MA plans must cover Part A and B benefits, but MA plans may not impose limitations, waiting periods, or exclusions from coverage due to pre-existing conditions that are not present in the original Medicare. MA plans may also cover extra benefits not covered by original Medicare, such as vision, dental, hearing. Supplemental benefits may be optional or mandatory. Mandatory supplemental benefits are embedded in the MA plan and must be purchased as part of the plan. They can include reductions in cost sharing for benefits covered under original Medicare. Optional supplemental benefits may be added to an MA plan at the option of the beneficiary. Beginning in 2026, we're starting to see some of the new features of 2026. MA plans are required to send members a mid-year notice of any supplemental benefits they have not accessed yet. What a relief. I personally use that at check-in to remind people that they have over-the-counter vision, dental, hearing, all the things to make sure that they're using them, especially with the dental and hearing and vision towards the end of the year, because you may have a lot of money socked away in benefits and in any other type of wallet that the plan may have that you can go spend on that. But now the plans are going to send that out to the members of the plan. So they'll know, and it'll be a reminder to use benefits that in past years have not been used. Medicare Advantage. The type of Advantage plans are coordinated care plans. These plans have a network of providers. It's a HMO. Some have a point of service benefit that allows beneficiaries to go out of network subject to limitations. There's also a PPO, We know HMO and PPOs from the working days, and that's what I love to remind people of, is that it's the same rules. HMOs have a defined network. PPOs, you can go in and out of network, but you'll go out of network at a higher cost. Private fee for service plans and MSA, Medicare Saving Account plans. HMOs generally only cover services provided by doctors and hospitals within the plan network. However, there are exceptions. Emergency services furnished by out-of-network providers are covered. When the enrollee is temporarily absent from the plan service area, dialysis services are covered outside of the network. Urgently needed services furnished by out-of-network providers are also covered. And if a specialist or a covered procedure is not available through the participating providers, the HMO plan will authorize out-of-network services. HMO enrollees are required to select a primary care provider, a PCP, from whom they will receive their day-to-day care. HMO enrollees may be required to obtain a referral from their PCP for specialty care like visits to a specialty physician to be covered. I will say, for those who are new, that's not as much of a thing now as it was in the past, but a lot of doctors do, even if the plan says we do not require a referral to see an in-network provider, that specialist may still require that referral and approval from the health plan, but the plan may not require it. Some HMOs offer point of service contracts. It's an option that allows enrollees to go out of network doctors and hospitals without receiving prior approval for certain services. Some of the services I love to talk about that are not covered in a POS is chemotherapy and mammograms, colonoscopies. All those things would have to be done in network. Unlike a PPO, an HMO POS plan will limit the services available out of network or may put a dollar cap on the amount of out-of-network coverage. Cost sharing is generally higher for services furnished by out-of-network providers than for services obtained from participating providers. PPO. PPOMA plans may get care from any provider in the U.S. who accepts Medicare and the plan. They are not limited to network providers. You will pay higher cost-sharing amounts to receive services from an out-of-network provider than from a participating provider. You do not need a referral or authorization to visit an out-of-network provider or receive services from them. However, it is recommended that you contact your plan to confirm that the out-of-network service you wish to obtain is medically necessary and will be covered. Beneficiaries may be required to get a referral or authorization to obtain certain in-network services or see certain providers. But if they fail to do so, covered services will still be paid for by their plan. They just have to pay the higher out-of-pocket or out-of-network cost sharing. Regional PPOs are PPOs that are offered throughout an entire region made up of one or more states. Special needs plans are a type of Medicare Advantage plan, HMO or PPO, specially designed to serve a targeted subset of Medicare beneficiaries. Can somebody tell me the most popular special needs plan? There's two. Can somebody take a stab at it for me? Okay. C-SNPs for chronic special needs plans and D-SNP duals. All special needs plans must implement an evidence-based model of care with appropriate networks of providers and specialists designed to meet the specialized needs of the plan's target enrollees. And all special needs plans include prescription drug coverage. That is on the test. All special needs plans include prescription drug coverage. Special needs plans. These are by far my most favorite plans to sell. I love them because it contains costs and it serves in my area, cardiac and diabetic people the best, and they are always beautiful plans that I've come across. Chronic condition special needs plans, known as C-SNPs, are plans that restrict enrollment to individuals with certain chronic or disabling chronic conditions specified in the CMS regulations. Those conditions include, but are not limited to, diabetes, stroke, and certain cardiovascular disorders, cancer, lung, HIV, dementia, chronic kidney disease known as CKD, certain mental health disorders, drug or alcohol dependence, or certain neurological disorders like epilepsy or Parkinson's. But by far, I work in multiple states. I will tell you that the heart and diabetes plan is the best, or is the most common, not the best, the most common. CSNPs focus on one severe or disabling chronic condition or a grouping as specified by CMS of severe or disabling chronic conditions that represent multiple conditions. Each CSNP will specify the condition or conditions necessary to be eligible to enroll. CSNPs offer supplemental benefits targeted to specific chronic conditions. There are two categories of such benefits, those that are primary health related and those are not. Addresses social determinants of health and are known as special supplemental benefits for the chronically ill, or SSBCI. You all need to pay attention to that. I am seeing a lot of the DSNP plans are not going to be offering some of the extra benefits that they have in the past. Just because they have Medicare, Medicaid, they will have to have a condition that ties a chronic condition that qualifies them for those services. It's still breaking news. It's still coming out. We're still hearing about it, but that is something to pay special attention to. Health-related benefits for the chronically ill may include, did I already read that? Yeah, I did. SSBCI may include items such as groceries, meals beyond a limited basis, pest control, and non-medical transportation. But again, here it's telling you those benefits will be tied to a chronic condition. I-SNPs and IE-SNPs. Institutional special needs plans are plans restrict enrollment to MA eligible individuals who for 90 days or longer have had or expected to need a level of service provided in a skilled nursing facility. A nursing facility as defined under Medicaid law. An intermediate care facility for individuals with intellectual and developmental disabilities, a long-term care hospital, inpatient psychiatric, or certain other facilities specified by CMS. Institutional equivalent special needs plan enroll MA eligible individuals who live in the community but require an institution level of care. Eligibility for IE SNP may be limited to certain assisted living facilities. That is on the test. You need to know what the IE special needs plan is, the institutional equivalent. It's MA eligible individuals who live in the community but require institutional level of care. Dual special needs plans, everybody's favorite. DSNPs enroll certain categories as determined by each state of individuals eligible for both Medicare and Medicaid. Dual eligible beneficiaries include beneficiaries enrolled in Medicare Part A and B, there's not an or, in receiving full Medicaid benefits and or Medicaid assistance with Medicare premiums or cost sharing. Eligible categories. Last year during the trainings I've put on, there has been a lot of questions. So I wanted to make sure that we spent time in the DSNP market just so that we could learn a little bit more. So let's jump in. Qualified Medicare beneficiaries, QMBs, our Medicaid helps pay premiums, deductibles, coinsurance, and co-payments for Part A and B or both programs for these beneficiaries. Special low income Medicare beneficiaries called SLMBs. Medicaid helps pay Part B premiums for these beneficiaries. QIs are qualifying individuals. Medicaid helps pay Part B premiums, and qualified disabled working individuals are QDWIs. Medicaid pays the Part A premium for certain people under 65 with disabilities who return to work. Medicaid may also cover medical costs that Medicare doesn't cover or partially covers, for example, nursing home care, personal care, and home and community-based services. Beneficiaries coverage can vary by state. Dual eligible individuals may also be eligible for full Medicaid benefits. Such individuals are known as full benefit dual eligible, which is FBDE or QMB plus. It's either or. They can be called both. FIDE, full benefit dual eligible. There are different types of D-SNPs, including fully integrated dual eligible, which is FIDE, special needs plans, highly integrated dual eligible, HIDE, special needs plans, and coordination only D-SNPs. FIDE special needs plans provide FBDE, which is the full Medicaid individual with access to Medicare and Medicaid benefits under a single organization that has both a Medicare Advantage and Medicaid managed care contract. FIDE special need plan membership is limited to individuals who receive their Medicaid benefits through the organization or parent or affiliate of the organization. FIDE special needs plans cover primary care, acute care, Medicare cost sharing, long-term services, and supports LTSS, including coverage of nursing facility services for at least 180 days during the plan year, behavioral health services, home health, medical supplies, equipment, and appliances. FIDE coordinates the delivery of covered Medicare and Medicaid services using aligned care management and specialty care network methods for high-risk beneficiaries. It also coordinates or integrates beneficiary communication materials, enrollment, communications, grievance, appeals, and quality improvement. All FIDE special need plans qualify as applicable integrated plans, but not all applicable integrated plans are FIDE special needs plans. If that's not confusing, I don't know what is. Any questions on FIDE before I move to HIDE? Okay. Y'all are a talkative bunch today. Special needs plans and coordinated only D-SNPs. HIDE cover certain Medicaid benefits under a capitated contract between the state Medicaid agency and MA organization. HIDE cover all Medicare benefits, and to the extent enrollees are eligible for these benefits, community long-term services and support, including some days of coverage of nursing facility services during the plan year or behavioral health services. HIDE special needs plans may also qualify as applicable integrated plans if they meet relevant conditions. Only D-SNPs do not qualify as HIDE or FIDE. They have a CMS approved contract with the state Medicaid agency that requires them to notify the agency or designated entities about hospital and skilled nursing facility admissions for at least one group of high risk, full benefit, dual eligible individuals. If a co-D-SNP enrolls only partial benefit duals not eligible for full Medicaid, it is not required to meet the notification requirement if the same parent organization offers an integrated D-SNP that enrolls full benefit, dual eligible individuals in the same state and service area. I haven't run across a lot of the coordinated only D-SNP plans. I haven't even really run across people who have them. So I'm not sure. D-SNPs applicable integrated plans. Applicable integrated plans are D-SNPs and entities with a Medicaid managed care organization contract with the state MCO that work together to coordinate Medicare and Medicaid benefits furnished to FBDE, full benefit duals, enrollees that the state requires D-SNPs enrollment to be limited to individuals enrolled in both MCO and a D-SNP. Applicable integrated plans include but are not limited to all FIDE and HIDE, as we've discussed, if applicable. QMBs are a type of dual eligible beneficiary. Special cost sharing rules apply to QMBs enrolled in any type of MA plan. So they're right there. They're saying it can even work with regular Advantage plans. QMBs do not have to pay more cost sharing than any minimal copayment that would apply under Medicaid, regardless of what the plan requires for other enrollees. All providers, whether or not they are Medicaid participating or a network, are prohibited by law from balance billing QMBs for any Medicare cost sharing amounts, including the amounts under their MA plan. Providers who balance bill are subject to sanctions. So the way that the QMB works is that it coordinates with the Medicaid, determining the level and what their cost share is. Anything beyond that, they are not responsible for, is not patient responsibility. Private fee-for-service, PFFS plans. Individuals enrolled in these plans may receive covered services from any provider in the U.S. who is eligible to provide Medicare services and agrees to accept the plan's terms and conditions of payment. That is on the test. They are not limited to receiving services from a network of plan providers. I would take a picture of the screen if I were you. Some of the PFFS plans contract with providers. If the plan has a network, enrollees may pay more if they see an out-of-network provider. Except for emergencies, enrollees must inform providers before receiving services that they are on a PFFS plan by showing their membership card so that the non-network provider can decide whether to accept the plan's terms and conditions. Non-network providers that accept original Medicare may choose not to accept the PFFS plan enrollees. Therefore, an enrollee needs to confirm that their provider of choice will accept a PFFS plan before enrolling in one. Very important. Do many of you sell private fee-for-service plans? Nope. Okay. Medical Savings Account, MSA plans overview. MSAs are high deductible Medicare Advantage plan that combine with Medical Savings Account. Medicare contributes money to the beneficiary's Medical Savings Account to assist with paying for Medicare covered services during the deductible phase. The amount of the contribution varies by the plan, and the money left in the account at the end of the year rolls over to the next year. That is very important. If the beneficiary remains enrolled in the plan the following year, Medicare will add additional deposits. If an MSA enrollee uses all the funds in their medical savings account, they must pay out of pocket until they reach their deductible. So after the annual deductible is met, the plan pays 100% for covered services. The maximum allowable deductible for MSA in 2025 is $16,350, but most of them have lower deductibles than that, but that's the most that they can have. $16,350. There is no premium for an MSA. MSA plans cover Part A and B benefits, but beneficiaries must continue paying their Part B premium. MSAs do not cover Part D Medicare prescription drugs. That's important as well. They will get a standalone PDP. MSA enrollees may receive covered services from any Medicare-approved provider in the U.S. if the provider chooses to accept their plan. MSAs may not have a network or may have a full or partial network of providers. So there's not a definition on how they have to build their network or not build their network. All non-network providers must accept the same amount that original Medicare would pay them as payment in full. This is the amount the enrollee will pay the provider before the deductible is met. So it's going to be Medicare allowable that they are going to be billed. Special eligibility rules. The following individuals are not eligible to enroll in the MSA. An individual who receives health benefits that cover all or part of the annual deductible under the MA-MSA plan. Example, primary health care coverage other than Medicare, Medicare hospice, certain supplemental insurance policies, and retirement health benefits. An individual who is enrolled in a federal employee health benefits plan, I almost said FEHB, plan, or is eligible for healthcare benefits through Veterans Administration, VA. Dual eligibles entitled to coverage of Medicare cost sharing under Medicaid, they cannot have a MSA. Those who will not reside in the U.S. for at least 183 days during the year, and an individual who is in hospice may not have a MA-MSA plan. Any questions? Okay, we'll keep going. Employer and union plans. Employers and unions may offer their retirees and their dependents MA individual plans available to any beneficiary. MA plans that are only available to individuals based on their employer, known as employer group waiver plans or EGWPs. MA plans offered through a direct contract between the employer or union and CMS, known as direct contract plans. Employers with less than 20 employees, as calculated under Medicare secondary payer rules, may be able to offer MA plans to their active employees and their dependents. Any size employer can offer MA plans to its retirees and their dependents. EGWP, which is, if you weren't with us yesterday, that is group coverage, and direct contract plans are different from other MA plans because enrollment is limited to certain active employees, retirees, and their dependents. A variety of regulatory requirements are waived as they apply to the plans. So the one thing that comes to my mind when we're talking about these type of plans is teachers, state employees, they have, a retirement plan that they are eligible for, and there are MA plans. So that's what that reminds me of. That certain subset group of employees, retirees, and their dependents are the ones allowed in those plans. And they're usually very nice plans, by the way. To be eligible to enroll in a Medicare Advantage plan, you must have Part A and enrolled in Part B. The beneficiary must permanently live in the MA's plan service area. If a beneficiary spends 6 months or more outside of the plan service area, they should only enroll in MAPD plans with travel benefits. Be a U.S. citizen or lawfully present in the U.S. on or before the effective date. CMS makes this determination. So if it is turned down, you can always let the beneficiary, instead of them being mad at you, you can let them know CMS made that determination. MA plans must enroll in any eligible beneficiary who applies regardless of health status. Special need plans only enroll beneficiaries within their targeted populations. Employer group waiver plans or direct contract plans may only enroll Medicare beneficiaries who are active employees or retirees of the employer or union offering the plan, EGWPs. It's on the test. Medicare Advantage premiums and cost sharing. MA plans may charge a premium. If a plan has a premium, beneficiaries must pay both their Part B premium and the plan premium to remain enrolled. MA plans may require members to share costs for covered services. A deductible is a set amount that the member must pay before the health plan begins paying. Co-payment is a fixed dollar amount per service that the member must pay. For example, $20 for PCP or $400 for each hospital inpatient stay. Of course, those are just examples. It may not be true. Coinsurance is a percentage of the cost of services that the member must pay. For example, 20% of the cost of durable medical equipment.
Hey, Taryn, we have a question on the slide just before this one. Faith asked if it included the spouse.
The plan, as it said before, to be eligible for this, EGWPs are open to spouses and the employee and the dependents. It's limited to active employees, retirees, and their dependents.
Thank you.
You're welcome. All MA plans must have a max out-of-pocket limit known as the MOOP for Part A and Part B benefits. Once the member pays a specified amount of cost sharing, the health plan covers 100% of covered medical services. Remember me asking that question earlier. Each year, CMS specifies the maximum a MOOP can be, which most plans have a lower max out-of-pocket. Each plan's MOOP will be specified in its summary of benefits and its evidence of coverage. For 2026, the maximum MOOP limit for MA coordinated care plans and private fee-for-service plans is $9,250. PPOs must also have an aggregate MOOP for network and non-network providers of $13,900. That is for next year. $9,250 and $13,900 for non-network providers as well, aggregated. MSAs have a deductible that members must pay, and then the plan pays 100%. I know I repeat myself, but that's how I learn. MA utilization management. Oh boy, UM. MA plans may implement mechanisms to promote the appropriate utilization of covered services. These are known as utilization management. That is on the test, what utilization management is. Such mechanisms include requiring a referral or a prior authorization to obtain services. PPOs may not require it for out-of-network services. PFFS plans may not require prior authorization, and non-network MSAs may not require prior authorization. So PPOs, PFFS, and MSAs may not require a prior authorization. Plans may also implement step therapy requirements for Part B or Part D drugs, or both. Step therapy is when a plan requires a beneficiary to try the less expensive option before stepping up to the drugs that cost more. When an enrollee becomes a member of an MA plan after starting a course of treatment, there is a minimum 90-day transition period during which the MA plan may not disrupt or require reauthorization for active course of treatment for new plan members, even if they are receiving these services from a non-network provider. I'm going to read that again because this is super important. When an enrollee becomes a member of a Medicare Advantage plan after starting a course of treatment, there is a minimum of 90-day transition period during which the MA plan may not disrupt or require reauthorization for the active course of treatment for the new plan members, even if they are receiving services from a non-network provider. Faith, I'm going to give my voice a break and have you ask you a question. So whenever somebody is scheduled for surgery and it's approved through United Healthcare, but they their commercial insurance, but they become eligible for MA plan, will that MA plan still cover that surgery?
She says she can't unmute. Give me just 1 second, Faith. Oh, you should be able to. You're enabled.
Okay.
Sorry, she can't unmute. I'm not sure what's up.
Okay, no problem. Charlie, the question goes to you. So if you have a prospect who you are talking to and they have a surgery scheduled and they are turning 65, retiring, going on a Medicare Advantage plan, will that MA plan still have to pay for that surgery that is already scheduled if it's within the minimum 90 days?
Yes.
You're correct. Very good.
I get a prize, Faith. It's mine, not yours.
Hey, don't be taking my girls' prizes. MA plans must offer at least one MA plan with prescription drug coverage, MAPD, in every service area. So that means that if they are primary MA only, which I don't see that happening, they must at least have one MAPD. MAPFFS plans have the option of offering prescription drug coverage but are not required to. That is on the test. The PFFS is throughout AHIP. So just pay attention to the PFFS plans from this point forward. An individual enrolled in a MAPFFS plan that does not include a Part D benefit may enroll in a PDP, even if under the same MA contract. The organization offers another PFFS plan that includes Part D benefit. So the question is going to be, do they have to offer it? The answer is no. Can they offer it? The answer is yes. And if they don't offer it, can somebody get a standalone PDP drug plan? The answer is yes. MSA cannot offer prescription drug coverage. That is also on the test. They may only get a PDP. If a MSA member wants drug coverage, the member must enroll in a standalone prescription drug plan. If a beneficiary enrolls in an MA plan that includes prescription drug coverage, the beneficiary can only receive Part D drug coverage through that plan. If a beneficiary is enrolled in an MA only plan, HMO, or PPO that does not include Part D, the beneficiary cannot join a PDP. They cannot, if they're enrolled in an MA plan, they may not get a standalone prescription drug plan. They will have to opt for the MAPD plan if they want drug coverage. If the beneficiary wants to remain enrolled in their MA only plan, they must choose an MAPD. Enrollees in certain employer union retiree group plans may have different options. Just always remember, if it is a retiree group plan, whether it's from employer, union, the state, they have completely different rules. And there are people who tend to work for those plans in that specified area. So always happy to look at them and tell them, the difference between a street level plan and that plan, but they will always have different rules than we do. Other types of Medicare health plans. There are other types of Medicare health plans which are not Part C or Medicare Advantage plans. The other types of Medicare health plans include cost plans, PACE, other demonstration plans. These are state-specific demonstrations, such as the Minnesota Senior Healthcare Options MSHO program. I copied that because I didn't know how to explain what a demonstration plan is, and I got that off of AHIP. So there's your answer. Cost plans are Medicare health plans that are not Medicare Advantage plans and not original Medicare. Cost plan enrollees can choose to receive Medicare covered services under the plan's benefits by going to plan network providers. The plan's cost sharing applies when the enrollee gets services from the network providers. Under Medicare by going to non-network providers. Original Medicare cost sharing applies when the enrollee gets services from non-network providers. This amount is missing a word. So basically what it's saying is if it's in the service area on cost plans specifically, this is not your normal MAPD plan. This is cost plan only. If it's an in-network doctor, the plan you're going to pay according to the plan. If they are out-network, you're going to pay according to original Medicare. Medicare cost plans may offer Part D prescription drug coverage as an optional benefit, but are not required to. That is also on the test. May offer other optional supplemental benefits, only available in certain areas of the U.S. In 2025, they were offered in 11 states, including some counties in Illinois, Iowa, Kansas, Minnesota, Missouri, Nebraska, North Dakota, Oklahoma. Go Sooners. South Dakota, Wisconsin, and Wyoming. And I have no idea why I said go Sooners because I am a cowgirl, OSU, Oklahoma State. An individual may enroll in a cost plan and a PDP. This applies regardless of whether the cost plan offers Part D coverage. The following individuals are eligible to enroll in a Medicare cost plan: those with Medicare Part A and B, or those with only Part B. Enrollees with Part B only will not have Part A coverage under the plan unless they purchase it. The plan may adjust the enrollee premium for individuals with Part B only. Any questions? Okay. PACE. I actually just had a client that was on PACE and left PACE. Programs of all-inclusive care for elderly is known as PACE. Medicare plans for frail elderly beneficiaries certified as needing a nursing home level of care, but still living within the community. That is on the test, that exact question. What plan is for frail elderly beneficiaries certified as needing nursing home level of care, but still living in the community? The answer is PACE. They are available in most states, but may only be available in a few counties. They offer an adult day health center where enrollees can get health care, meals, and other in-home referral services. Eligibility for PACE: age 55 or older, reside in the PACE organization service area, be certified as eligible for nursing home care by their state, and be able to live safely in a community setting at the time of enrollment. PACE plan benefits: there's no deductible or copayment for any drug, service, or care approved by the PACE team of healthcare professionals. Beneficiaries with Medicaid pay no premiums. Beneficiaries with only Medicare pay a monthly premium to cover the long-term care portion of the PACE benefit and a premium for Part D in addition to the Part B premium. Any questions on PACE before we move into appeals and grievances? Okay. Appeals and grievances. Enrollees of Medicare Advantage plan, Medicare Cost Plan, or PACE plan have the right to file complaints, which are known as grievances. Grievances are complaints, including complaints about the quality of their care, get a decision about a health care payment or service or prescription drug coverage, get a review, which is an appeal. So a complaint is a grievance and a review is appeal. I don't know how many years it took me to get that. So I love to always point that out because it was always opposite in my brain. So get a review is an appeal of certain decisions about healthcare payment, coverage of services, or prescription drug coverage. Grievances are used for complaints about the operation of a plan or its network of providers. Enrollees or their representatives may file a grievance if they experience problems with healthcare service, such as timeliness, appropriateness, access to care, cleanliness, a procedure or item. Grievance issues also may include complaints that a covered health service, procedure, or item furnished during the course of treatment did not meet accepted standards for the delivery of healthcare. An enrollee or their representative may make the complaint orally, in writing, or via a CMS website at medicare.gov, my/Medicare complaint. Medicare Advantage, Medicare Costs, and Medicare prescription drug plans must also provide a link on their websites to the medicare.gov website where the enrollee can enter a complaint. Whew, that's a lot. Coverage decisions. Coverage decisions are determined and made by Medicare health plan regarding whether a medical care or prescription drugs are covered, how they are covered, and the beneficiary's cost share. Examples of when an enrollee may need coverage decision is a prior authorization to provide a furnished service, to obtain payment for certain items and services, also payment for urgently needed services, to continue the service that the enrollee believes is medically necessary, to obtain a payment for a prescription drug, to ask for an exception from a plan's formulary requirements, including step therapy requirements or tiering. An enrollee has the right to ask for prior authorization, even when it is not required, to find out if the service will be covered by the plan. So whenever I was making this to continue a service that the enrollee believes is medically necessary, that is most oftentimes, for those who are new, that's going to be when it comes to specialty scans, especially. Those sometimes need a little shove. Appeals. The appeals process is used to ask for review of the plan's coverage for payment decisions. If an enrollee is not satisfied with the coverage decision, they or their physician can appeal the decision. An appeal is a formal way to ask the plan to review or change a coverage decision. Physicians can appeal prior authorization denials on behalf of their patients. An appeal can also be filed if an enrollee believes a Medicare health plan did not pay for or authorize a service that should have been covered. Where the plan did not pay, the enrollee must be financially liable in order for the appeal. So if they do not bill the enrollee, they still can't file an appeal on behalf of their physician or health group or hospital or whoever it may be. An enrollee believes the plan has not authorized or paid for Part D prescription drug that should have been covered. Medicare health plans must provide enrollees with written description of the appeals process. Medicare health plans must include on their websites written procedures for filing appeals or grievances, along with phone numbers for receiving oral requests, mailing address for written requests, and links to any forms created by the plan for appeals and grievances. Medicare health plans offering a Part D benefit must provide access via secure website or secure email address on the website for enrollees to quickly request a coverage determination or appeal a decision about coverage of a drug. Require network pharmacies to provide enrollees with a printed notice with the plan's toll-free number and website for requesting coverage determination regarding a prescription. And that is where I got all my information. My name is Taryn. I am the Director of Provider Referral Operations and Agent Training, and Charlie is a manager under me. So if ever you have questions, you can always reach out to us. And if you are not part of our team, we welcome you to join us. Okay, so let's stop sharing this. Wow, we have a room full. When did that happen? Does anybody have any questions? And maybe it's me who needs to unmute everybody.
I have a question, Taryn.
Oh, maybe not. Okay, yeah. What's going on, Lisa?
So with the pre-auth, does when a pre-auth is required, how much time does the health plan have to respond to that request?
Are you talking about a pre-authorization or a prior authorization?
Probably a prior, whatever it would.
The permission to go to a specialist?
No, the permission to get a procedure done.
Yes.
Or the permission, yeah.
That's the same thing. Yes. So that's the permission to get something done. 99% of those are auto-generated to be approved if it's normal stuff. 90%. What was that number, Charlie? I think it was 99 or 90%. So they have, I believe it's 30 days to get that approved or denied.
Wow, that's a long time if we're talking about.
It never takes that long. That's how long they have, and they have 45 days to make payment to the plan. As I mentioned before, it's usually done. It's through a portal. The computer recognizes its guaranteed codes and will approve it. And then in other instances, like it may take longer if somebody is needing to go to a rehab hospital, and that may take longer to get approved through the plan versus an appendectomy. Does that make sense?
It does. But what about like MRIs or CTs or PET scans or something like that? When they, what is the time frame? Is it still 30 days?
There's just not a time frame. That's generally what they say. But those are going to be the things that typically get bounced back, and they will look at it more in depthly to see if it's medically necessary. And then they would have the right to approve it or deny it. When you're talking about specialty scans such as MRIs and PET scans and CTs. Now it can be requested on an urgent basis, and those have to be approved within, 24 hours, I believe is the case.
I have a question. If a member is on an MAPD and they're in and out of a nursing home or skilled nursing home, and the nursing home people try to set up PACE for her, how does that work? It's confusing to me when it
PACE is through Department of Human Services. So right. If they have questions, I would go to the social worker of the skilled nursing facility, and they would be able to get them in touch with their person at the DHS to help them with the PACE.
And she has a hard time writing and getting across what she wants to say to them, and they're not being very cooperative. So they were supposed to file some paperwork for her, and they didn't.
I would call that DHS and try to speak to the caseworker to say that this individual would has one. I don't know. I just tend to get a little bit more involved than I should. Does she have a authorized person to help her?
It just came in the mail because it wouldn't go through the email. from Humana. So it just came through the mail and I've got to get it to her.
I had somebody who was on PACE and they requested to be removed from PACE and got put on a regular plan, but they live in like a senior apartment, if that makes sense. Yeah.
Okay. Thank you.
You're welcome. But everybody have a great evening. Get an AHIP, start taking these tests, and let's get certified. Thank you.